23, we will continue with malignant tumors. First we have seen the benign tumor, so now we will continue with malignant tumor. So we see here, you can see in the diagram renal cortex, medulla, and the renal carcinoma that is there in the picture. They have given about renal artery, vein, ureter, cancer in the renal pelvis. Okay, so we'll go to the renal tumor. So when we say renal cell cancer or hypernephroma, so when we say hypernephroma, it usually affects the renal tubules. Okay, is a serious pathological condition of the kidney. Renal cell cancer originates from small renal tubules. As I told you, it affects the renal tubules. So it starts with the small renal tubules of the kidney. Kidney tubule functions as a filtering apparatus of the body. So these renal tubules help in the filtering of the waste products. Okay, so that gets disturbed. What are the various causes? So when we see the causes, it is mainly with age factor. It is usually known to occur, already we have seen, of the age group of 50 to 70 years. Hereditary factor, the exact cause of renal cell carcinoma is unknown, or hypernephroma is unknown. Etiology is actually idiopathic. Okay, the family history of renal cancer, if there is a family history, then the others also are prone to develop. Hereditary is one of the causes, not yet eliminated. Okay, then we have non-steroidal anti-inflammatory drugs. So when the person is taking on long term of NSAIDs, are said to be prone of developing this cancer of the kidney. Then occupational hazards, we have seen exposure to chemicals like asbestosis, cadmium, lead, chlorinated solvents, and petrochemicals. Already I gave you an example also. One brother, he was working in abroad, so he was involved as a pathologist, okay, as a pharmacist, something related to the medicine. So unknowingly one day on the pipette, when he aspirated, that chemicals went into his body and it affected the kidney. So now he is on renal dialysis because he ignored taking the tablets which was prescribed to him. Okay, so actually chemicals can have ill effect over the kidney, leading to cancer. Then dialysis, several years of dialysis may be the triggering the cancerous activities of the renal cells. So even prolonged period of doing the dialysis also affects the kidney, leading to renal cancer. So these are the various causes. Next we will see what are the various risk factors. So it can be hypertension, horseshoe shaped kidney. So here it is also called as renal fusion. What happens congenitally, there is a fusion between the two kidneys forming a U shape. So if you have seen horseshoe, it is like a U shaped. So that's why. So kidney becomes like that because of the fusion of the two kidneys, which is congenital. So because of this, we call that horseshoe shaped kidney. And in this case also, it is a risk factor where a child, okay, or an adult can develop renal cancer. Polycystic renal disease, already we have seen, sacs, the membrane, okay, of the kidney, which is filled with fluid, multiple sacs, that is polycystic renal disease. Then tobacco use and obesity is also one of the cause. Okay, so these are the various risk factors which can lead to renal cancer. Next we will see what are the clinical manifestation. So non-specific symptoms of renal cell cancer or hypernephroma, what are those? So if a question is asked on hypernephroma also, you should be able to write about this malignant carcinoma. So weakness and fatigue, loss of appetite, loss of weight. Okay, then when we say specific symptoms, patient will be having pain. Okay, so moderate to severe flank pain often radiates to lower back. That's where the kidney is located. So the patient will be having severe flank pain also, we've been seeing, right? So often it radiates to the lower back. Severe abdominal pain will be there. Intensity becomes severe following abdominal examination. When they press and do, okay, when they do the inspection or palpation, automatically it also increases the intensity of pain in the patient. Next we will see that there will be abdominal mass. So abdominal mass is felt during examination on the right or left side of the umbilicus. So when you do the palpation, we will find out where exactly it is. It can be on the right side or it can be on the left side of the kidney. Urine discoloration will be seen, that the urine becomes dark brown or red because of bleeding from cancer into the renal tubule. Increased erythropoietin secretion. So deep vein thrombosis will be there for the patient. Polycythemia, that is increased RBC. Then decreased erythropoietin secretion. So at certain time there will be increase and certain time there will be a decreased. So in case of decreased, you will see that the patient is having pale skin and anemia, and also that there is a bleeding into the renal tubules, right? So it leads to anemia. Increased angiotensin secretion will be there. So it affects it when the angiotensin secretion is affected, it leads to vision problem, hypertension, night sweating in the patient. When you see diagnosis, you'll see that the patient, what are the diagnostic procedure? Usually history collection, physical examination, urine examination. So in urine examination, we will be able to find out hematuria, blood in the urine, proteinuria, flank bread, okay, fresh blood that is there in the urine, bacteria in the urine will be there. Then blood examination, all we have to do is CBC, total blood count. So WBC cell also will be increased. That is because of kidney or bladder infection will be there. So that is called as leukocytosis. Increased WBC leukocytosis, red blood cells when increases, it is called as polycythemia. So this is also increased because of the secondary erythropoietin secretions. Next you have platelet count. So elevated secondary to increase. So erythropoietin is increased, again the platelet also increases. So increase, abnormal increase of the platelet count is called as thrombocytopenia. Okay, cytothemia. So remember all these terminologies. Okay, next you have hemoglobin test. When you do, we know that it will be reduced because of the bleeding, and it's secondary to decreased. So we have seen phases where it will increase, where it will decrease. So when it is decreased, we'll see that the patient's hemoglobin also is decreased. In few cases it happened. Then ESR, when you see because of the infection rate, ESR will be increased. Then kidney function test, blood urea nitrogen, okay, so that will be increased. Creatinine level will be increased because the kidney is not able to function normally. Then liver enzyme test, as I told you, AST, ALT will be elevated because the waste products are not removed. Then image studies, when you do like CT, MRI, ultrasonography, finding or pilogram, finding of the image studies, like solid mass is observed around or within kidney tissue. We will be able to find out a hard mass, irregular margin of the tumor. Malignant, usually it will be irregular, it is not a perfect shape. Okay, so irregular margin of the tumor will be assessed. Renal mass will be cystic or calcified. So it will be either cystic filled with fluid or it will be calcified, hardened. Then lymph node tumor mass. So you will see that lymph node, if the patient is having malignancy, lymph node also will be enlarged, spread off, and it will be enlarged and becomes big. Spread of tumor in renal vein. Okay, it leads to renal vein metastasis, and metastatic tumor also you will see that like vertebral column, lungs, brain, thyroid, okay, liver and abdominal organs also will be affected. So following image studies are performed. So when you do image studies, you will be able to find out various metastasis. Okay, spread of the tumor, that is metastasis. Then you can see if there is an enlargement in the lymph node itself, that can be observed. So following image studies are performed, like CT scan, MRI, renal arteriography, intravenous pyelogram, ultrasound. So all these will reveal, the findings of the image studies. So better you can first write the image studies and then you can write the findings of the image studies. Interchange 8 and 9. Okay. Then you have biopsy. So we know that when we do biopsy, we will be able to detect renal cell carcinoma. Okay, whether it is malignant or it is just a tumor, could be find out. Okay, and then management, surgery for renal cell cancer or hypernephroma. So radical nephrectomy, which is the removal of the kidney, removal of the lymph node and adjacent soft tissue, that is called as radical nephrectomy. Then you have laparoscopic nephrectomy. Through the laparoscopy, surgery can be done. So through that laparoscopy, where they put small holes and they will remove the kidney, okay, affected part. Then lymph node close to the kidney, whichever lymph nodes are there near the kidney also will be done. So this is about the laparoscopic nephrectomy. So we have seen radical nephrectomy, laparoscopic nephrectomy, so where the lymph nodes are also removed, and then partial nephrectomy. Solitary well localized tumor with no sign of metastasis is partially removed by performing partial kidney excision. So only partial part which has affected, that will be removed if there is no case of metastasis, no spread to the adjacent body parts. Then you have radiofrequency ablation. So radiofrequency, we know that needles are inserted under CT guidance into the renal cell cancer mass. The tip of the needle heated with radiofrequency waves. So they will send radiofrequency waves of about 80 to 900 Celsius, and total tumor mass is ablated. So here heat waves, okay, the radiofrequency waves are sent, okay, which affects about 80 to 100 degree of Celsius will be sent, and it will destroy the cancerous tissue. radiofrequency ablation. Next we will see cryoablation. So radiofrequency ablation, here the heat is more, where 80 to 100 degrees Celsius is given. In cryoablation, it is a surgical probe where an instrument will be passed and they will send extreme cold gas. It can be argon gas or it can be liquid nitrogen can be sent, where it will be too cold, minus 700 degree Fahrenheit. So you can imagine how much cold it is. So they will pass this cold liquid or cold gas. Again, this freezing point, okay, this coolness will go and cause freezing to the tumor cancer cell and the cells are destroyed. So that is called as cryoablation. So cryo probe, when we say, it is a surgical probe, a long slender pointed surgical instrument used to apply extreme cold to tissues. So example, liquid nitrogen or argon, ARGON, argon gas is passed to destroy the tumors. Okay, next you have, so all this comes under surgery. Okay, radical nephrectomy, then laparoscopic nephrectomy, partial nephrectomy, radiofrequency ablation, cryoablation. Next you have chemotherapy for renal cell cancer or hypernephroma. So here we see that several chemotherapeutic medications will be given. Results are not that encouraging. Then you have thirdly immunotherapy for renal cell cancer or hypernephroma. So here we see that activation of the immune system they do by activating, so white called cells attack tumor cells. So they will give this therapy so that the WBC will increase, so it will attack the tumor cells. Next, so these are all the various management: surgery, then chemotherapy, immunotherapy, replacement. Okay. Next we will go to complications of renal cell cancer or hypernephroma. So we know that whenever it affects the kidney, automatically it affects the heart, leading to hypertension. Excessive calcium will be there in the body, elevated RBC, which is the polycythemia, liver dysfunction, metastasis. Next we will see what are the nursing management. So nursing management, we have to administer prescribed analgesics as needed by the patient. So provide analgesics for the patient to reduce the pain. Prepare for nephrectomy as indicated. So you can write preoperative and postoperative. So preoperative, as we been saying, assess the condition of the patient, monitor the vital signs, check all the blood reports, mainly HIV, hepatitis B. Okay, now you have to include even COVID-19. Okay, so all this tests should be done, and then X-ray, okay, CT, whatever has been done, make sure that the reports are collected and informed to the surgeon. Okay, and then you have to make sure that you have to get ready with the blood bank. Consent before the surgery has to be taken. Nil per oral, enema in the night should be given. Patient's nails should be cut. Skin preparation according to the prescription, according to the surgeon's order, skin preparation has to be done. IV fluids has to be given to the patient. Check hemoglobin. Okay, and keep ready with the blood bank. How many bags, what WBC you are going to give? Whole blood, are you going to give whole blood, or are you going to give only PCV, packed cell volume? You have to confirm that with the blood bank. All the tests has to be reported. Whatever you do, it has to be reported to the surgeon. Okay, so yeah, so that is all about preoperative care. Then provide symptomatic treatment for adverse effects if the patient is having. For chemotherapeutic drugs, we have to give. Then watch the patient. Usually when we put the patient on chemotherapy, they will have, vomiting will be there, diarrhea will be there, tiredness will be there, anorexia will be there, insomnia can be there. So symptomatic treatment has to be given when the patient is on chemotherapeutic drugs. Watch the patient for signs and symptoms of pulmonary, neurology and liver dysfunction. Usually it affects the lungs also, so we have to be very careful that when patient is taking chemotherapy, we have to monitor all these side effects and monitor laboratory tests for anemia, polycythemia and abnormal blood chemistry. Even the electrolytes we have to see, and we have to know if the patient has got any less of electrolytes or any other blood decrease is there or increase is there, that has to be reported simultaneously to the surgeon. And then watch for adverse effects of radiation or chemotherapy. Monitor the patient's degree of pain and assess the effectiveness of analgesic. So we have to assess for pain and we have to see for the effectiveness of the analgesic. Tell the patient what to expect from surgery and other treatments. Explain the possible effects of radiation and drug therapy. So we'll have to tell them. Sometimes when the patient is on radiation or chemotherapy, they tend to lose all their hair. Okay, eyelids they lose, eyebrows they lose. Okay, so aesthetic need for beauty, right? So self-esteem. So we have to give them adequate psychological support. If fully hair is gone, advise them to use wig, okay, so that they don't feel bad, or might cover their head, giving psychological support. We have to tell them what they have to expect after the surgery, you know, like healing. So medication for pain will be given. They have to do post-operative exercises, explain the side effects of radiation and drug therapy, explain stress the importance of compliance with any prescribed outpatient treatment. So whenever required, they have to come. So usually this people, you know, so people are there who do not develop much of side effects, but there are people who will be having lot of side effects. So whenever required, they have to come to the hospital, show to the doctor who is treating them, to prevent further complication. Then encourage the patient to express his anxieties and fears and remain with him during period of severe stress and anxiety. So very important that they, you know, ask doubts, talk about their anxiety, so that, you know, their pain, you know, their sometimes anxiety will increase the pain. So ask them any doubts, clarify the doubt. If you don't know, ask the physician, okay, and tell to them, don't give wrong advice, don't give wrong counseling to the patient or wrong information to the patient. It is okay if you, because we do not know everything, right? So you have to ask, and then you have to clarify if you are giving them the right or the wrong answers. It is very important. So with this, we have done the malignant tumor. We have seen what it is, the definition, the various causes, risk factors, symptoms. We have seen non-specific, where they have weakness and fatigue, loss of weight, loss of appetite. Specific are like pain, abdominal mass, urine discoloration, increased erythropoietin secretion or decreased erythropoietin secretion, increased angiotensin secretion. The diagnostic procedures, then under which 10 points we have seen, and then management that is required for the patient, that is surgery, and then you have chemotherapy, immunotherapy, complication, nursing, management.